Alright guys, now that you had a chance to take a break, we're going to pick up with drug toxicity. Now within the geriatric population, this population takes approximately 1/3 of all prescription medications within the United States. They also buy the greatest number of over-the-counter medications. Because they tend to have many coexisting diseases, they're at greater risk for drug interaction from prescription medications. And this is ultimately because of the decreased in kidney function, liver function, to where now it's not able to properly filter those drugs out of the body after they've taken them, as well as because of possible issues with memory or vision. They may accidentally take multiple medic pills of the same type. Treatment includes maintaining their ABCs, ensuring that they're able to ventilate and oxygenate properly. If you do suspect drug toxicity, even if you don't suspect drug toxicity, if the patient has any medications, always transport the medications with the patient. Delirium and dementia can either be a chronic issue or a short-term issue. If it's chronic and irreversible and can be severely worsened by infection, medication change, trauma, or another acute condition, this is your dementia. Changes in mental function are normal with aging, but approximately 15% of those over age 65 develop severe dementia with profound disturbances within their cognition, including loss of short-term memory and decline in judgment, intellectual ability, and abstract thought. Management of the dementia patient is ultimately supportive. Delirium can also result in an alteration in mental status. However, unlike dementia, which is a chronic condition, delirium presents with a more recent and sudden onset. Delirium is often described by family members as starting abruptly and can present with delusions. The patient may have a history consistent with a delirium episode, which can include intoxication or withdrawal from alcohol, sedative use, infectious medical conditions, dehydration, fever, stroke, blood sugar level abnormality, psychiatric disorder, malnutrition, hypoxia, endocrine disorders, or even environmental emergencies such as hypothermia. Management, just like that of dementia, it's supportive, maintaining your ABCs, and treating anything that you can find as you consider going. Treatment of patients suffering from Alzheimer's disease or any other form of dementia requires special compassion from the EMT. Naturally, you must take necessary actions to establish and maintain your airway, the breathing, oxygenation, and circulatory systems. However, you will transport these patients in a non-emergency setting. At times, you may even find the patient uncooperative, even combative, with biting, spitting, and even punching. So it may help to enlist the assistance of a caregiver the person trusts. Remember that the uncooperativeness and aggression are symptoms of the disease. They are not conscious acts of aggression against you personally. Many geriatric patients who fall do not develop life-threatening injuries and do not die from the fall. But certain injuries are common among those who fall. So that's why we want to make sure that we assess for hip fractures, head injuries, chest and abdominal injuries, spinal fractures, and fractures of the hand, wrist, forearm, or shoulder. Now this is going to be one of the more common things that we go to as far as falls. And the reason that it's a common cause of trauma death in the geriatric patient, it's not because of the fall itself. It's because they may have fallen and they literally cannot get up. Head injuries are harder to detect in the geriatric patient. As mentioned previously, the brain is shrinking in size during the aging process. Even though there is additional CSF surrounding the smaller brain, there's still more space in which the brain can swell or blood can accumulate in response to the injury. When looking at a patient that has any kind of trauma or shock, you want to try to figure out what may have resulted in this. Did they become dizzy? Could they have had palpitations, and instead of it being, them tripping, it may have been a cardio issue. So now we may be dealing with a medical problem as well. Treatment of patients that have had trauma must be executed expeditiously because they're not able to compensate for it as well as they used to. Provide spine motion restriction precautions during your primary assessment if necessary. Administer high flow O2 if poor perfusion is evident, and provide positive pressure ventilation if the patient is breathing inadequately. Findings that support the field impression of a GI bleed in the geriatric patient include hematemesis, or vomiting blood. That will be seen in your upper GI. Hematochezia, or red undigested blood and bowel movement, would be seen in a lower GI bleed. Melena, or dark tarry bowels. This would be indicative of a digested blood, and this would be indicative of an upper GI bleed as well. Dyspepsia, or indigestion. Hepatomegaly, an enlarged liver. Jaundice, or yellowing of the sclera and skin. Constipation, diarrhea, agitation. Your signs and symptoms of a GI bleed may be obvious, where you can obviously see the bleed, or it may be occult or hidden. Your approach and assessment should be similar to any other assessment format for the geriatric patient. Focus on ensuring a patent airway. Provide positive or manual or mechanical airway resistance if the patient cannot protect the airway himself, possibly because of a depressed mental status. If breathing is adequate, provide supplemental oxygen to maintain an SpO2 reading of 94% or greater, and if breathing is inadequate, provide positive pressure ventilation. You may also consider doing a orthostatic blood pressure check by measuring their blood pressure from their laying, sitting, and standing. If you have a drop in blood pressure less than 10 when the patient's standing than when they are supine, this would be a positive tilt test and indicative of a volume depletion. Due to their skin becoming thinner, they have less of ability to thermoregulate. Treatment of the geriatric patient prone to hypothermia includes protecting their airway and maintaining normal breathing and circulatory status. Not only should you remove the patient from the cold environment, but you should also remove any wet clothes and insulate the patient in a dry blanket. Use caution when handling or removing a severe hypothermic patient, as this excessive movement or handling can place them into a lethal heart rhythm. Geriatric neglect is the withholding of care from a provider of attention or medical care that the victim is entitled to. This type of neglect can occur passively or actively, the difference being the intent of the care provider. With passive neglect, the failure is said to occur unintentionally and is often the result of the care provider feeling overwhelmed by the needed tasks, or that the care provider simply does not know or understand the care or interventions that the patient needs. Patients that suffer from this type of abuse, whether it be neglect, physical or sexual, emotional or financial abuse, are usually bedridden, have some type of neurocognitive disorder, frail, have disturbed sleep patterns, are all at a high risk of falling victim to abuse. The abuse that they may suffer, definitely if it's physical or sexual abuse, can have dire consequences because of the patient's frailty, because of their thin skin, because they may be taking blood thinners. that now you have this pooling with it around the eye, the pressure being placed on the eye, and causing issues with the patient's vision. Many indications that we may, as EMTs, may encounter, both physical and emotional, can point to abuse. Your primary role is to provide assessment and care for the patient. Do not try to investigate the suspicion of abuse or attempt to confront the alleged abuser. That is not our job. However, do report your findings or suspicions to the medical staff or PD if they are on scene, and provide thorough and objective documentation in your pre-hospital care report. Always consider approaching the geriatric patient with the same degree of concern and consideration that you would show a pediatric patient. In addition, avoid any of the purposeful or accidental stereotyping of ageism. Ageism occurs generally when a person either knowingly or unknowingly discriminates against people who are old. Probably the two greatest social issues are isolation and marital status. With advanced age comes the loss of many friends and family near their own age. This isolates the geriatric patient from the rest of society as their social network continues to decrease. One consistent feature of almost all living arrangements is that the EMT may be delayed in getting to the patient's side due to locked doors of care facilities, privacy gates in adult communities, or simply waiting for the patient's primary care provider to arrive and give the patient's medical and physical history. Attempt to obtain as much information as possible from the patient. Advanced directives are designed to express the patient's wishes as to the care they want to receive should they experience a significant change in their health. For example, a geriatric person with uncurable cancer may have had advanced directives prepared on their behalf should they later experience another significant health crisis. Because the depth and breadth of advanced directives vary from state to state, you as the EMS personnel must become familiar with how they are handled in your state and EMS system. Because of the normal aging process, the response to illnesses are altered. Many medical problems present with different signs and symptoms in the geriatric patient than within the general population. For example, as already noted, a lack of chest pain within a geriatric patient who experiences a heart attack is common. In general, the geriatric patient needs to be assessed and treated carefully. Any delay in recognizing healthcare needs and providing care can have devastating and irreversible consequences. Patients who are at particular risk for these possible conditions are those that live alone, and they may have fallen and they can't call somebody. They're incontinent, where they're unable to control their bladder, and they continuously wet themselves, and now they're developing pressure sores or skin degradation. They're immobile. They've been recently hospitalized or recently bereaved. When the geriatric patient shares living quarters or lives within an extended care facility, numerous patients can be victim to an environmental emergency, such as temperature extremes or toxic fumes. So you want to assess for any hazards. Look at the environment. Also, you want to determine whether or not any additional patients are present and call for additional resources if necessary. You also want to determine whether this is a true medical or a traumatic or combined problem. Table 39-3 in your book goes over some clues that could be found in your scene size-up to help you lead into what may be going on. Although you may make a preliminary determination of the nature of the problem during your scene size up, always maintain a high index of suspicion, looking for clues to either chronic or acute conditions. The geriatric patient's mental status can also be influenced by a chronic illness, the present illness or injury, prescription drugs they take, or relative familiarity with their surroundings. The purpose of assessing the mental status is to determine a baseline level of consciousness and the possible need for airway protection and ventilatory assistance. It's also important to ask family or caregivers to describe the patient's normal mental status. You may have to repeat information because they're processing information more slowly. So you may tell them something and have to wait a few seconds as well. Geriatric patients normally process information more slowly than their younger counterparts. The stress and confusion of emergency can also slow them even more. Try to find conditions that may have been causing their issues in mental status. If the patient's agitated, you want to look for clues to hypoxia because that is a leading cause of agitation in a normally calm patient. Other causes could be poor brain perfusion, stroke, infection, trauma, drugs or alcohol, or even altered blood glucose levels. Go through and assess your airway. And remember that the geriatric patient's diminished gag reflex makes them vulnerable to aspiration of fluids and food or other solids, which can be fatal to the patient. If the patient has dentures in and they have become loose, you want to take them out so that way they don't complicate airway management. However, if they are still in place and they are secure, leave them be so that in case you have to provide positive pressure ventilation, it's much easier to secure the bag. Don't get a false sense of security if the patient's rate begins to slow. This can indicate respiratory failure rather than improved oxygenation. These patients also have a higher resting respiratory rate and lower tidal volumes due to pulmonary stenosis. These patients, when they go into respiratory failure or have respiratory distress, they're going to tire out a lot quicker, and they'll eventually stop breathing much quicker than their younger counterparts. Make sure that you maintain an O2 sat of 94%. And if they're not breathing adequately, provide positive pressure ventilation. Within their circulation, you want to make sure that you assess central and peripheral pulses, noting rate, strength, and rhythm. With the rhythm, you want to note any irregularity to the heart, because this could be cut from some type of degenerative process that is affecting the conduction system of the heart, or from a drug that the patient takes. Resting heart rates are also higher, unless the patient is on some type of beta blocker where it's lower. An irregular pulse is also common within the geriatric patient if they are not taking medication for it. The geriatric body also does not display the same signs and symptoms of dehydration as in the younger patient. Because the geriatric patient has overall a lower amount of body water, and because of changes within the skin from aging, dry looking skin and poor skin turgor could be normal within the patient. So instead you want to look at your mucous membranes for any signs of dehydration. Determine whether or not the patient is stable or unstable, and determine your transport priority. When progressing into your secondary assessment, when interviewing these patients, you may encounter characteristic challenges resulting from the general depression of sensory organs. These changes in their sensory organs and sensory changes may affect their history taking, where they may not be able to hear you as well. Also, just because they're old does not necessarily mean that they are deaf. So don't automatically assume that they can't hear and start yelling at them. Position yourself in front of them. Explain what you're doing to them. If they can't hear you at first, slowly work your voice up. but also check to see if they have hearing aids and make sure that they are turned on. Um, if the patient has eyeglasses, make sure that they have them on. You can expect increased anxiety because of an inability to see surroundings, coupled with an inability to exert control over the situation. So make sure that you are calm and be in a position where the patient can best see you. If the patient has any cataracts or glaucoma, you may need to keep lights dim to help them be able to see a bit better. Many geriatric people cannot hear high frequency speech, especially consonants. Obtaining a history can be difficult if the patient cannot understand questions. Do not assume that the patient is deaf without first inquiring with family or bystanders. If the patient is hearing impaired, write it down. Write what you're needing to say down. I've done it before multiple times. Examine their head, neck, chest, abdomen, pelvis, extremities, and posterior body, looking for any evidence of trauma in the geriatric patient that you suspect trauma. Keep in mind, because of the aging process, they are at a higher chance of injuries in things that when they were younger maybe not would have been as prominent. The geriatric patient may also not report everything that is wrong with them. If you have doubts about whether the patient can grasp what you are saying, you may want to make sure, subtly of course, that a family member or bystander is also hearing and noting the information given. Table 39-5 goes over some considerations within vital signs with our elderly patient. Their respiratory rate and heart rate may be slightly higher than in the elderly than it would be 10 years prior. In infectious diseases, because of the immune system's decreased ability, fever is less common in them. Their pupils may also be more sluggish to respond to light, not because of medication or because of taking drugs, just because of the aging process. They may be distorted because of cataract surgery, and they may have eye drops that they have to take because of such as glaucoma. Approach the patient with concern and compassion and talk to them about the emergency rather than talking about the patient to others unless unavoidable. If you have some doubts about whether the patient can grasp what you're saying, you may want to make sure that a family member or bystander is also hearing and noting the information just to verify what they are saying. You must distinguish signs and symptoms of chronic problems or natural aging processes, which can be very difficult to do without help from a family member or caregiver, from the signs and symptoms of acute problems. Loss of skin elasticity and mouth breathing can give the false appearance of dehydration. Edema can also be caused by varicose veins, inactivity, and position rather than heart failure of the patient. Questions should include the following, such as having any trouble breathing lately, cough, chest pain, have you been eating and drinking normally? And keep in mind that they may not report or fully report all complaints, or they may give you 20, 30 different complaints. Listen to them, work with them, figure out what's going on, but try to get as much information as you can from them. The geriatric patient is not set at ease when an unknown person or EMT arrives on scene and talks to them as if they have been friends for years. It's inappropriate to address the geriatric patient by their first name or a nickname and contributes to ageism uh, stereotyping. The only exception to this is if the patient voluntarily tells you otherwise. So when you come in and you say, "Hey, my name's for me, for example, I come in, hi, my name is Joe, with the ambulance service. What seems to be going? Can you tell me your name? My name is John Smith. All right, Mr. Smith. What seems to be going on today? Well, my chest is hurting, but you can call me John. Okay, so it's okay if I call you John? Yes, sir. All right, cool." And then continue on. And now that he specifically said that it's okay for you to call him John, you can call him John. To ensure appropriate care of the patient, reevaluate the patient frequently. Length of time spent with the patient or the condition of the patient can assist in establishing how often to repeat the reassessment phase. If the patient is stable, monitor reassess every 15 minutes. If they are unstable, at least every 5 minutes. Make sure that you anticipate any issues that may arise. Be prepared to assist ventilations and maintain oxygenation. And make sure that you keep the patient in the proper position for transport. Alright guys, that concludes this chapter. If you have any questions, please be sure to email them to me or send them to me and remind. Make sure that you are knocking out your Brady Labs. If you do find that you have a question in Brady Lab, please be sure to send that to me as well. Otherwise, I will see y'all next time in class. Y'all have a good rest of your day. Talk to y'all soon.